Hello, welcome to the IAACD Global Professional Education listening and sharing session for 2025. Today, we're going to be talking about optimizing health and well-being in adulthood. And the speakers today are Dr. Ed Hurvitz, Dr. Christina Sarmiento, and Mary Gannotti, physical therapist. Um, we are going to be presenting this session in English, and our outline will include talking about optimizing kidney and bone health and function, optimizing preventative care, and then talking about exercise and physical activity and well-being. And then there'll be some time for a discussion. So first, I'd like to introduce Dr. Ed Hurvitz from the University of Michigan.
Hi, everybody. As Mary said, my name is Ed Hurvitz. I'm at the University of Michigan in the United States, in the state of Michigan. I am in the Department of Physical Medicine Rehabilitation, which means I'm a physical medicine rehabilitation physician. I take care of people with disabilities, particularly people that grow up with disabilities like adults with cerebral palsy. Our research group has been looking at the outcomes of adults with cerebral palsy for the past 15 years or so. And today I'm going to focus on a couple of issues. Although there are many things we could talk about, we'll focus on a couple of issues today. Next slide, please. So the first thing we're going to talk about is chronic kidney disease. So as many of you probably know, the kidneys clean our blood from toxins and regulate the fluid in our body. But the kidneys are subject to disease, and when that happens, it throws off a lot of our body systems. Adults with cerebral palsy have an increased risk of kidney disease. Well, why is that? There's a few reasons that we've identified, but some of the most common are adults with cerebral palsy tend to have more hypertension than the general population. This is probably related to the fact that they tend to have more body fat and they tend to be less active and less fit, so hypertension becomes a problem. The other thing is that many people with cerebral palsy were born prematurely. And when a child is born prematurely, the kidneys are not fully formed correctly, and that can lead to a risk of chronic kidney disease as they get older. Chronic kidney disease can lead to all kinds of problems, including the need for dialysis, the need for a transplant, and potentially other problems that could lead to a shorter lifespan. Next slide, please. So the issue that we want to bring up today has to do with how we detect chronic kidney disease in people with cerebral palsy. Your doctor will measure your kidney's health by measuring the creatinine. Creatinine is a substance that's found in muscles. If your creatinine is low, that means your kidneys are working well. Your kidneys are clearing your blood of the creatinine. If it starts to increase, it can mean the beginning of kidney disease. Now, as I said, creatinine comes from muscle, and people with cerebral palsy have less muscle. We see the pictures there. They're from two people that are about the same age and actually about the same weight. And we see that the top picture is someone with cerebral palsy, and the picture below is somebody without cerebral palsy. And we see at the same age and even the same weight, the person with cerebral palsy has much less muscle mass. And because they're the same weight, that means they'll have a lot more fat mass. So people with cerebral palsy have less muscle. Less muscle means they're making less creatinine. And when they measure the creatinine in the blood, it's going to be lower than would be expected. And so the kidneys will appear normal, even if there's kidney disease. Even if the creatinine would normally be high in someone with a normal muscle amount, in the person with cerebral palsy, it'll look normal because they have so little creatinine to start with. Next slide, please. So how would that work? So a person goes in for their regular checkup, they get routine blood work. The creatinine is 0.4 and normal adult level is 1.3. The next year they come in for repeat blood work, and now the creatinine is 1.2. So the doctor says, no problem, your creatinine is still normal. And then there's no treatment. But look what's happened. The creatinine levels have tripled, the kidneys are failing, and it wasn't even detected because it's all still within the normal range. Next slide, please. So we need faster diagnoses to get better outcomes because early kidney disease should lead to increasing treatment of hypertension, changes in diet, and other things that might help the kidneys slow down from their failing. we don't want to get into a situation where we need significant kidney disease treatment because there may be, as bad as that is for anybody, for someone with cerebral palsy, there may be the extra problems of access issues. For example, getting transportation to and access to a dialysis site. Yes, they provide vans, but will they always be accessible? And also, when we think about dialysis and transplants, those things are often rationed because there aren't as many dialysis machines, aren't as many kidneys for transplant, and there's a lot of ableism which may interfere with somebody with a disability getting that treatment. So we need to avoid this completely. So at what point should we be sending patients to see a nephrologist, a kidney doctor? Next slide, please. So we need to monitor for kidney disease. We need to yearly check-ins with people with cerebral palsy to look at their blood work. The risks increases with age. Generally, past 45 years old is the most significant. But we have found in our research that people with cerebral palsy tend to get these kind of chronic diseases early on. So maybe we should start really focusing on this when somebody gets into their 30s. So the thing we have to do is look for a pattern, not just a number. So I've shown over there a slide, a imaginary graph of somebody who's creatinine, and they come in and get measured every year, and it's slowly going up and up and up and up and up. And when it gets to 1.5, your doctor says, "Oh, your kidneys are abnormal. We should go see the kidney doctor." But look, let's go back to the green arrow. At the green arrow, your kidneys, it's actually the number has gone up 3 times. So at this point, even though it's normal, your doctor should be concerned and think about sending you to the kidney doctor. Another solution for this problem, aside from this kind of monitoring and awareness, is something called cystatin C. Cystatin C is not dependent on muscles. It's another way to measure kidney health, and it can be a very effective way to do that. And so it may be a better test for someone with cerebral palsy. Next slide, please. So you may ask yourself, what can I do about my kidney health now? Well, one thing is to work with your doctor to help educate them about what you've learned today and to advocate for monitoring. There is something out there called the Adult Toolkit, which contains some of this information. People should look at picking that up. It's from the Cerebral Palsy Research Network, and it contains some of these kinds of information in it, and it can help you with educating your doctor. Make sure that your high blood pressure is being treated. What are the best treatments for high blood pressure? Losing weight and exercise. Is it hard to exercise? Well, try to move more. The graph on top shows from a study that we did, which looked at the amount of sedentary behavior, which is just sitting around, in people with cerebral palsy. And we see this tremendously high, even at the levels of gross motor functional classification scale, that a system that are people where people can walk, still a lot of sedentary behavior. So getting up and moving around is one of the best solutions to helping with treating high blood pressure. Also, compliance with your medications, taking the medications that you're supposed to give for your blood pressure. And I didn't put this here, avoiding certain other medications, talking to your doctor about medications you may be taking for pain, which may have effects on the kidneys. Something to really discuss with your doctor. Next slide, please. Let's move on to that to talk about bone health in adults with cerebral palsy. Next slide, please. So fractures are common in cerebral palsy at all ages. In the two graphs you see here, there's a dark black line on the top and a gray line on the bottom. The dark black line is looking at people with cerebral palsy, and the gray line is people who do not have cerebral palsy. But when we look at women, we see that when they get into their 40s and 50s, the number goes up in both groups. And we all know about that. That's when women start having menopause and start having more problems with their bone health and get more fractures. But all through the lifespan, completely through the lifespan, women with cerebral palsy have more fractures than women who do not have cerebral palsy. Looking at the men and the boys, we see something that surprises us a little bit. One is that at the age of 12 to 14, there's a real spike. Now, that's not so surprising. When people get to about 12, 14 years old, they get more mobile, they move around more, and more fractures may occur. There's also puberty at that age, some growth spurts, and that may affect some things as well. So it's not so terribly surprising. But look how the fractures go up with age, even though this doesn't happen in the typically developing population. There is no menopause, of course. And so we see that it's a very high risk for males as they get older for reasons completely unrelated for the reasons it is in women. So let's talk about some of that. Next slide, please. So fractures in studies we found can lead to all kinds of illnesses and even early death. There's all the pre-fracture factors. What are pre-fracture factors? Those are things that cause a higher risk of fracture. And in people with cerebral palsy, one of the main things that causes the higher risk is their bones do not develop normally as they go through childhood. They're not as strong, they're not as dense, and that leads to a risk of fracture. So when a fracture occurs, there's all these things that can happen post-fracture. There's loss of function, loss of independence. And when there's loss of function, people stop moving around as much. When they stop moving around as much, there tends to be more inflammation in the body, which leads to atherosclerosis, blocking in the blood vessels, muscle wasting, and all kinds of other problems that lead to various diseases and various losses of function, which lead to morbidity, which means illness and sickness, and mortality, which means passing away. So we can improve and even save lives if we address bone health and do better screening and treatment in adults. Next slide, please. So again, why do people get with CP get fractures? I mentioned the bone development and it's altered, and the early osteoporosis, which means weak bones. Some of this has to do with decreased weight bearing, and some of it may have to do with how spasticity affects the bones. And then there's falls. People with cerebral palsy fall more often than people who don't have cerebral palsy. They have a difference in their strength and sensation from the typical developing population, which leads to a risk of more falls. And once they feel they're falling, because of their lower amount of control over their muscles, they have less ability to react quickly. And then there's the effect of chronic diseases like diabetes and kidney disease, which affect the nerves, and polypharmacy, including medications given for mental health issues like anxiety and depression, and spasticity medications, which can sort of cut the cognitive edge, make people a little bit less aware of their surroundings, and put people at risk for falls and then subsequent fractures. Next slide, please. So we need to take better care of bones. So first off, screening for bone health. Generally speaking, people don't get screened for bone health until they have a fracture. But we feel that adults with cerebral palsy should be getting more screening earlier with something called a DEXA scan. A DEXA scan looks at your bone density, your body fat, your muscle mass. Here's a picture of a results of a DEXA scan, which shows us all of those things. And then we have to think about after fracture care. We did an interesting study that showed that people who have fractures, adults with cerebral palsy have fractures and don't get PT/OT afterwards, can have an increase of morbidity and mortality. Why do we think that is? Well, when people fall and fracture, they get afraid to move. People with cerebral palsy might be even more afraid to move. Decreased mobility leads to increased disease. And so PT helps increase mobility. OT can look at your environment and help make it safer and make it safer in the way that you take care of yourself to prevent you from falling while you're doing your daily care. Next slide, please. So what can you do now? One, evaluation. Talk to your doctor about getting a DEXA scan. Two, strengthen muscle and bones. And people sometimes think exercise means sweat, but no, we tell you do resistance exercise. Use weights. Do you have to lift 150 pounds? No, lift 5 pounds, 10 pounds, whatever you can lift. And I think Dr. Gannotti will talk even more about this in her talk. Walking is a great exercise. Rolling, I should have put in, is a great exercise. Any exercise is good. And looking at diet to make sure your weight's under control. And there's fall prevention. We talked about PT. Looking at your house. Do you have proper lighting? Do you have loose carpets? Reviewing your medication. Are you taking too many drugs that sedate? Getting your vision and hearing checked because that can contribute. Making sure you have proper shoes and making sure your equipment's in order. Don't let your braces your walker or your canes collapse on you and lead to falls. So there's a couple of points about kidney disease, about bone issues. And now we're going to hear a little bit more from Dr. Sarmiento about preventive care. And thank you. Stay healthy and keep moving.
Thank you, Dr. Hurvitz. So I'm Christina Sarmiento. I'm also a physical medicine and rehabilitation physician. I'm at the University of Colorado, and I see children and adults, all ages that have childhood onset disabilities or lifespan disabilities, particularly cerebral palsy. And I'm going to be talking a little bit more in depth about primary care and preventive screening. Next slide, please. So, as we learned about kidney health and bone health issues, adults with CP have a higher risk of many chronic conditions. And some of these are listed here on the right, things like diabetes, asthma, high blood pressure, which we learned from Dr. Hurvitz, stroke, arthritis, and mental health conditions. Adults with CP also have a higher risk of having multiple chronic conditions, and all of this at earlier ages compared to adults without CP. Next slide, please. So primary care and preventive screening is important because it can lead to earlier detection and treatment of many of these chronic conditions. And we know that earlier detection and treatment is beneficial to health. And so comprehensive primary care and preventive screening can help with this earlier detection and therefore earlier treatment. In the United States, as similar to many other countries, we have standardized guidelines for preventive services. This is regardless of whether one has a disability or not. And these are based on age and sex, as well as some of them are based on risk factors. Next slide, please. And so what is included in this under this umbrella of preventive care? So this can include medical tests to help identify conditions earlier when they're typically easier to treat. These include things like colonoscopies to screen for colon cancer and mammograms to screen for breast cancer. But preventive care also includes services that help prevent diseases. And these are things like annual flu shots and regular dental cleanings. And preventive care also includes education and counseling by the primary care provider on healthy habits and unhealthy habits, things like smoking, alcohol drinking, diet, weight, and exercise. So all of this is considered preventive care. Next slide, please. However, we know that adults with disabilities in general, so not CP specific, but overall in general, receive lower rates of many of these preventive screenings, and that's a problem. Perfect. We can click maybe a couple more times.
Let me click over.
That should be good. Perfect. Thank you. So we conducted a study, the three of us here, as well as Jocelyn Cohen from the Cerebral Palsy Alliance Research Foundation, to help identify adult CP research priorities. Our overall goal was to advance research about adults with CP using the CP Research Network's infrastructure to co-create a multi-center research agenda that was focused on adults and aging with CP. So this was a qualitative research study, so we conducted focus groups, first with individuals with CP and caregivers, then focus groups with clinical investigators, and finally focus groups with community leaders and advocates. Next slide, please. And we can click one more time. Thank you. During our focus groups, we asked participants among these three areas that we discussed, bone health, kidney health, and preventive care, which was their highest priority for the adult CP research agenda. And what we can see from this slide is that preventive care was most commonly ranked as the highest priority for among these three. So you can see here 52% of participants who voted identified preventive care. Bone health was not far behind, and overall participants felt like all three of these areas were very important to continue researching and improve our understanding and management. Next slide, please. This was a little bit about what participants told us about preventive care. So the issues and the barriers to preventive care were relevant across focus groups. This particularly rang true for women's health, so things like cervical cancer screening, breast cancer screening, and there are a lot of barriers brought up related to healthcare system accessibility. So it's great if your provider orders a mammogram, but then is the mammogram machine accessible? The transition to adulthood was identified as a particularly challenging time, a time when there's changes in providers, as well as services and insurance coverage, as well as this outdated view of CP as a static childhood condition. Participants identified the need to educate the CP community to empower them to self-advocate with their providers, like Dr. Hurvitz was talking about, as well as a need to educate healthcare providers on these unique healthcare needs and health risks of adults with CP. Here are some quotes from participants in our study. So one adult with CP told us, I think most people feel like CP is just a childhood thing. It's not. It's a lifelong condition, and the lack of providers in the adult world to take care of us and to really know and understand what we're going through on a day-to-day basis is really, really frustrating. You can click again. Thank you. Another adult with CP told us, I find they don't, even if I bring up a mammogram or I bring up some kind of preventive screening, it gets pushed to the side, like it's not important in my case. And finally, another adult with CP told us, my primary care doctor is more or less of a joke when it comes to my CP. Next slide, please. Relatedly, there is an online health tool that was initially developed for individuals with Down syndrome called Down Syndrome Clinic to You. This online health tool was designed to improve adherence to healthcare guidelines and to inform Down syndrome specific care for patients with Down syndrome. And this tool was tested in a randomized controlled trial, and overall there were very high levels of both patient and provider satisfaction. And so our next steps, having understood that preventive care is a priority for the adult CP research agenda, we're going to use principles called implementation science to adapt this Down Syndrome Clinic to You tool for adults with cerebral palsy. So Cerebral Palsy Clinic to You. Next slide, please. This is what Down Syndrome Clinic to You looks like. So it is a online health tool through a web-based platform. Users create their own account, and then they fill out this intake form, which is an online health questionnaire. And you can see there are questions related to demographics, their diagnosis, current medical and mental health concerns, recent blood work or other testing that they've had, their past history, immunizations, and so on, including nutrition, school, life skills, as well as connection to the Down syndrome community. Based on an individual's responses to this intake form, they get individualized output, and that output comes in two forms. So there's user-facing output, which includes individualized screening recommendations and resources that are based on their responses to the intake form. Online, this looks like a web-based checklist, but could also be printed out as a PDF. And there is also output for the patient's primary care provider, or PCP. And this is in the form of a letter to the PCP that describes what this tool is and how it was based on evidence, and provides information on and evidence for the recommendations provided. And this is given as well to the user to bring to their next primary care visit to help facilitate a conversation that is more informed about the unique health risks of individuals with Down syndrome. The way that this is intended to be used, so for the user, its goal is to increase the patient and family's knowledge and education related to Down syndrome specific risks, and to provide resources, to increase their awareness of what preventive services are recommended and why, and to help facilitate that self-management and self-advocacy piece. For the primary care provider, it's intended to give evidence for care recommendations and provide Down syndrome specific knowledge to a primary care provider who might not be as familiar, and to facilitate efficient as well as patient-centered care decisions. Next slide, please. This is a screenshot of what the tool looks like online. So for Down syndrome, since all individuals with Down syndrome have some degree of intellectual disability, it is more geared towards their caregiver. So this is called the caregiver plan. This is that user output. So these were the labs, tests, and procedures that were recommended for this hypothetical patient AB. So you can see here an audiogram or hearing test was recommended, and it also provides information why. So for this study, it says up to 75 of every 100 individuals with Down syndrome have hearing loss. So it gives a reason why this screening test was recommended. And this continues for every recommendation provided based on the individual's responses to that online health questionnaire. Next slide, please. This is a screenshot of what that primary care provider letter looks like. So it says that, the caregiver of your patient completed this online healthcare tool. It says who developed it, provides a link to more information about it, and provides some recommendations and resources that they hope find helpful during their next visit with this patient. Next slide, please. This is what the primary care provider sees in terms of recommendations. So you can see it's a little more succinct, but still lists the same services or healthcare screening tests that were recommended for the caregiver's output version. So for audiogram hearing test for ages 21 and over, experts recommend an audiogram every 2 years, given the increased incidence of hearing loss. So it explains the evidence behind the recommendation as well. Next slide, please. This is what we anticipate doing for cerebral palsy clinic to you. So you can see we plan to use the same general format. This is a work in progress, but our anticipated adaptations are noted in red. So we anticipate that this will live online through the Cerebral Palsy Research Network's community-facing platform. We anticipate that we'll add additional topic areas to ask questions about, so things like current function and changes in function, as well as highlight some specific issues that commonly come up in the primary care setting, like bowel and bladder management, pain, and spasticity. And then finally, for the individualized output, we anticipate adding suggested adaptations for some of these screening tests based on the adult with CP's function. So if they have a higher degree of physical disability, what are some troubleshooting or adaptations that can be done in the clinic or in the healthcare system to help make these screening tests more accessible? Next slide, please. Overall, this is our long-term goal and our long-term hypothesis about how this tool may be helpful. So you can see there are many barriers to comprehensive preventive care for adults with CP. Everything from lack of providers and resources to provider discomfort or lack of provider or patient CP-specific knowledge. The barriers that we think might be addressable, or at least partially addressable by this online health tool, Cerebral Palsy Clinic 2, are noted in green. So we recognize this tool is not going to fix every problem, but we hope that it's a step in the right direction to ensure that every adult with CP receives CP-informed care and education. So we hope that this tool can increase patient self-efficacy and self-advocacy, help facilitate communication between patient and provider, and help improve provider comfort as well in taking care of individuals with CP. Then we hope that this helps increase adherence to preventive services and increase the degree of patient-centered care, with the long-term goal of decreasing chronic disease burden, improving function and quality of life, and decreasing issues that are common among adults with CP, like chronic pain and fatigue. Next slide, please. Here are some references based on the slides that I talked about today, and I'm going to now pass it to Dr. Mary Gannotti. Thank you so much.
Hello, my name is Mary Gannotti. I'm a physical therapist and I am a professor at the University of Hartford. And like Ed, I've been interested in adults with CP for about 15 years. And one of the first things that we were looking at was function and how function changed after orthopedic surgery in childhood to adulthood. And so, in fact, although CP, the brain injury for CP is non-progressive, the functional abilities and the symptoms people may experience might change with aging. And so we're going to talk about maybe what things will change and what you can do. So first of all, we know adults with CP lose function. They have a high risk for pain, and that they can definitely benefit from physical therapy and exercise. It doesn't cure everything, but it certainly helps a lot. We have a community registry at the Cerebral Palsy Research Network where adults with CP can sign in and complete surveys and tell us about their functional abilities and how they might have changed since childhood or on a year-to-year basis. In the first analysis that we did of 264 people, we saw that, in fact, there was about 60% of the folks that reported change in gross motor function. There was a small percentage that reported improvement, and that's in blue for hand function and communication. But you can see that generally we have more people reporting decline than they do improvement. And we see about 27% for hand function and 9% for communication function. When we look more carefully at who in fact is reporting the change, the gross motor decline is more likely to happen in the levels 2, 3, and 4. And those gross motor functional levels are classifying your ability to ambulate, where people who are level 2 are more likely to ambulate without an assistive device, but might be a little bit slower. Level 3, you may use an assistive device. And then level 4, you might only have exercise ambulation abilities. When we look at functional change by age, it's no surprise that in fact, with increasing age, we see an increased risk for reporting decline. Particularly gross motor decline increases by age. We also can see that with hand function, and we didn't have, we start to see that with communication function, but we didn't necessarily have a large enough sample size for that. We do have a larger sample now, and we can explain some of the variability in communication a little bit better, and that information is forthcoming. When we asked people why they were changing, it's no surprise that people were most likely to report pain was the cause of their change. And this is for gross motor function. Also, fatigue is a big reason why people change in their ability to locomote. And we also see that people report changes in strength, increasing weakness, and changes in spasticity, or the appearance of dystonia. And I think that that's a really big surprise for a lot of adults with CP, that with age, they can experience a change in their spasticity that might significantly impact their ability to walk and, in fact, their balance. And like Dr. Hurvitz had said, that puts them at greater risk for falls. So there's the need for the assistive device. And for many people, that is something that's quite astonishing to them, that now they need an assistive device to walk when previously they did not. And this change can occur at different ages. In terms of chronic pain, we did note that about 78% had chronic pain, and we had about 73% of the people complete information about the chronic pain and the features of the chronic pain that they did experience. People reported that the average onset of pain that limited their function was really about 28 years. We do know that people with cerebral palsy have always kind of have pain in the background of their experience, but as they age, you tend to see the increasing pain interference. And interestingly enough, pain intensity didn't vary by people's functional abilities or their age groups. And that makes sense because pain is a subjective experience. It's an individual, personalized experience. And it makes sense that it wouldn't necessarily go along with your level of physical ability or your age. When we gathered up the body parts where people did have pain, it was very interesting to note that people with cerebral palsy just don't have one area of pain, but on average, these folks were reporting 8 areas that were painful. And I think that's pretty significant. The most common area is the low back and the hip and the legs. This pain is also not well treated. Most of the folks, about 70% of them, reported having 50% or less pain relief in the last 24 hours. So the pain is poorly managed. So this is not a very good picture. People are experiencing changes in function because of pain. They have pain all over their body, and it's not well managed. And this is something that we're working on, trying to uncover more information about. We know, however, and of course I'm a physical therapist, so I'm going to wave the flag of exercise, but right now it's a really, really potent treatment that we have. because not only can exercise address pain, it can also address fatigue and changes in strength that occur. And there's really high levels of scientific support, not necessarily in the cerebral palsy population, but in the general population, that exercise reduces pain in the low back compared to no treatment, usual care, or a placebo pill. And it also may be more effective than education or electrotherapy. So exercise is very potent for low back pain. It's also been shown to be really potent for knee pain from arthritis. And we also know that the low back pain in the knee were areas of very highly people who commonly had issues in their low back and knee. And there is some evidence that just increasing your heart rate will give you an overall sense of well-being and some pain relief as well. So as Dr. Hurvitz said, just move, roll any way you can, increase your heart rate, and it's going to have a positive effect on your pain. Another important area is mindfulness. And mindfulness is the basic human ability to be fully present, be aware of where we are and what we're doing, and not be overly reactive or overwhelmed. And it's a skill that needs to be developed, because imagine in this day and age that it is reactions and stress is high. And ways to practice mindfulness are to be still, just to simply concentrate on your breathing, maybe have a visual point, practice gratitude, observe the sensations in your body, and just pull your mind inward to what's going on. And then move intentionally. When you go to do your exercise, move intentionally and link your movement with your breath. And this might sound very much like yoga, and it might sound very much like Tai Chi, which are very potent as well for addressing pain. And you can see that there is evidence to support mindfulness for low back pain. It's not really clear if it's as effective for knee pain. But it's really also great for your anxiety, and anxiety and depression tend to co-occur with pain. And it can reduce some of the pain interference if you reduce your anxiety and your depression. There's also biophysical agents, and those are things like hot packs, cold packs, massage, dry needling, and transcutaneous electrical nerve stimulation. I know there's lots of barriers to these techniques for people with CP to use them at home. They might not have the physical capacity to put on the TENS or the hot packs, and might need someone to do that. And that might be a barrier. Massage is not generally covered by insurance, and the massage is something that is very effective, but you might have to private pay for it. Dry needling is an emerging technique that is also very effective, and you can get that from your physical therapist. We in fact did a case study looking at combining yoga and TENS to address low back pain. And we treated a 61-year-old male with spastic diplegia who had increased spasticity for the last 5 years, and he had a decrease in function. And we had 2 conditions. We treated him one time just with yoga and TENS, and the next time with yoga and sham TENS. And we used this technique called quantitative sensory testing on some patient-reported measures. And the results were that adding the TENS activated the descending analgesic pathways. We were able to measure that with the quantitative sensory testing. and that he actually got more pain relief. So some of these words on the slide say that he did have central sensitization of pain. Some of his pain was not exactly from his low back. It was manifested throughout his body, and he was overreactive. But he did experience complete relief of pain after using the yoga in either the active or the sham tens. But adding the tens definitely provided a deeper pain relief as measured by quantitative sensory testing. So as a physical therapist, I'm really interested in techniques where we combine interventions. And I think this is a really cool application of that. Reducing biomechanical stresses is also really important. And if you don't know about NCPAD, NCPAD is the National Center for Health and Physical Activity and Disability. It's in the United States, but they have a program called NCPAD Connect, where that they will do an intake, and they will assign you to a program. And one of the programs is NCPAD Mentor, which is a 4 times a week program online where you practice mindfulness, exercise, nutrition coaching, and you learn about resilience. And this is a group program, and you get some exercise equipment and instruction, and it's 8 weeks long, and has been shown to be effective in adults with disabilities, and we're using it with adults with CP as well. You also might want to think about changing your lifestyle, using a scooter rather than always walking, having some different equipment or bracing. You might want to think about energy conservation, using a rolling bag or taking other forms of ways of conserve your energy. And then exercise purposely, like Dr. Hurvitz said, use resistance weights and purposely try to strengthen some of your muscles in a certain way. The other thing I want to bring to everyone's attention for those of you who live in the United States is that maintenance therapy is covered by Medicare. And maintenance therapy is when someone needs skilled physical therapy to maintain their function or prevent or slow deterioration. And oftentimes the physical therapist says, I can't see you anymore. The insurance won't cover you because I need to prove that you are going to reach your maximal potential. So that is what is called restorative therapy. But skilled maintenance therapy, it's also known as compensatory therapy, focuses on sustaining your current function and preventing or slowing a loss of function. And it requires a skilled physical therapist. This is very helpful for folks, but however, clinics are not oftentimes providing this service to individuals because they're afraid that Medicare won't pay for it. But I would, it's been covered since 2014, and people should advocate that if they need therapy to exercise, if they need skilled physical therapy to exercise, that it is covered. And that's all I have to share with you on the slides today. I think that we did mention the Cerebral Palsy Research Network several times, and maybe perhaps I'm going to bring up the website really quickly. And
Wonderful. Thank you
wait,
very much, Mary, and everyone. Can you hear me okay?
yeah, I just wanted to show a slide, Bernadette, if that's okay. I mean, the
That'd be
web
great.
page for our toolkits. So if you go to cprn.org/our toolkits, you can see the different toolkits that we have. This one is for people when the child is just diagnosed, the CP toolkit. This is a toolkit for people with dystonia. This is for well-being for parents and caregivers. And this is the adult cerebral palsy toolkit. It's 174 pages. It's free to download, or you can buy it on Amazon for $19.99. And it provides a lot of the current evidence that we have for health and well-being, as well as information from people with lived experience about living your life as an adult with cerebral palsy in terms of navigating social issues and employment. So I encourage you to check those out.
Since we have a few more minutes, I wonder, Mary and Christina, if there's any other points we'd like to bring up. You know, one of the things I want to mention, our group wrote a paper called Navigating the Pathway for Care, and talked about some of the barriers there are for people with cerebral palsy getting care. Christina, you mentioned some of those things, but we broke it down into three categories. There's problems with the system, problems with the provider, and there's things that the patients have to consider themselves. So, you know, the system type problems is that we're just not set up for care, this kind of care. People with cerebral palsy is thought of as a pediatric condition. So the pediatric providers don't want to see adults, the adult providers don't want to see children. So these kind of clinics don't get set up in the system. Sometimes having a clinic that really addresses the needs of a cerebral palsy, adult with cerebral palsy is not efficient, and it doesn't make the kind of money that other clinics do. All these kind of things are blocks in the system. As far as providers, education is a big problem. People just don't have the knowledge. And Christina, your work with CPC2U, I hope, is going to make a very big impact on that. And you know, the providers out there know what I'm talking about, and I'd like the community to know as well. When you're a provider and you feel that you don't know what's going to happen with the patient that you're treating, you don't want to hurt people. I mean, you always want to do the best for people. You don't want to hurt people. So I don't want to give people medications if I don't know how they're going to react. If people with cerebral palsy react differently to certain treatments, and I don't know that, it makes me very hesitant to want to do that. And that's, I think, why studies have shown that a lot of practitioners don't like to treat people with disabilities. It's very unfortunate. And the third
Well,
thing, go ahead. Go ahead, Mary.
Just to piggyback on that, Ed, I tell adults with CP to go to physical therapy, and then they tell me the physical therapist said there was nothing they could do with them. So we have the same issue in the PT world, and we are working really hard. That's part of the toolkit. There's information in there by physical therapists that you can share with your physical therapist. And in fact, we are trying to do lots of education in the PT community because they feel like you're an adult with CP, you've had this your whole life, you know how to deal with it. But that's not true because changes do happen. And we would advocate for you to go to a PT every year to monitor your function and to use the information and the evidence that is out there, specifically in the toolkit, to advocate for PT.
Christine, any comments on any of that?
I totally agree, and I think, you know, with the online health tool that we're adapting, yes, I think the goal is to provide that bi-directional education, and I think that's what we heard from our qualitative study that we did with Jocelyn, is that we need to educate providers, and also adults with CP and others with lived experience told us themselves they want this information. In those focus groups, we shared similar information that we shared today about kidney health, bone health, function, pain, and a lot of adults with CP that we talked to said they were hearing of a lot of these risks for the first time too. And so trying to improve that communication in all directions to improve that education.
Yeah, I think I find that one of the things the patients crave most is information. You know, rather than pills or shots, or I mean, those are good too. And you know, Mary, when we talk about physical therapy, our physical therapist, Dana Ryan, in our clinic, she educates. You know, she just like you do. You know, she educates because people just aren't given information. They're ejected out of the pediatric clinic and put on their own, and it's very difficult.
What was I going to say? No, I forgot. Hmm. Oops.
Well, when you're cooking on that, Mary, I just wanted, what I was going to say about the patients themselves is that unfortunately, people with cerebral palsy have a higher prevalence of depression, anxiety, and also have problems that we found even high functioning people with some executive function issues. So the clinicians out there should know that you just can't say to someone with cerebral palsy, you should exercise more. You should, the more direction is very, very helpful. And, hopefully the tools that we've been talking about, the tools that Mary just showed, is a way that you can help your patients to have more direction, to get more information that they can use to help themselves.
Well, another thing, Ed, I think that I was going to say is I think the fact that the messaging that particularly the folks that are adults now had received as children was that this is what you have, and it's never going to change. And quote unquote, I'm 18, I beat it, I'm here. Now I'm just going to go through and it's a big shock when the spasticity changes. When they get a kidney stone and then they fall and then the spasticity, and all of a sudden they have to use a wheelchair or a walker. And so I think that you're completely right about the anxiety and the depression. There's a grieving process that people go through and an acceptance. And when the healthcare professionals are not aware of that and can't support them through that and help them equilibrate to the new normal and accommodate their new situation, it's very difficult. So education is really key.
Yeah, so I just want to make one more comment. We talked about our fourth author, co-author, Jocelyn Cohn. Jocelyn Cohn and I did a grand rounds together. We called it 10 Things We Would Like Our Physician to Know About Adults with Cerebral Palsy. I chose 5, she chose 5. And most notably, I remember was number 5 and 6. For number 5, I said, you have to be your own advocate. It's important that you are your own advocate for your healthcare. And Jocelyn's point 6 was, I'm sick and tired of having to be my own advocate. I'm exhausted from having to be my own advocate. So I'm very hopeful, Christina, that CPCTU is going to be a big, big tool for helping advocate, that the adult toolkit that CPRN produced that we all worked on is going to be another way to help people advocate, because it is not easy.
No. And it's really hard when I tell you to go to PT and a PT says they can't do anything for you. So,
yeah. Well, I want to thank the IACP for this opportunity, and I hope that we get a lot of people watching this video, because I think we gave everybody some good information.
Incredible information, and couldn't be more grateful. And I will definitely be advocating for how important this session was. An incredible speaker. So thank you all for your time and efforts on this. Greatly appreciated.
Okay. Everybody have a great, great weekend. Bye-bye.
Thank you. Have fun, Christina. Thank you, Ed. Thank you, Bernadette. Bye-bye.